The smartphone has practically become a body part to most of us. We wake up to it because it's our alarm clock. We check the weather because it's our weatherman, read the news because it's our newspaper, interact with our friends on social media, email, and messaging apps, or whatever form we have. We use it as our map on our way to work. We order our coffee and even use it to pay for our coffee like a credit card. Throughout the day, it is our window to the world, our door to open and see and speak to others, and so much more. We hail rides, track calories and weight, and when it's broken, our world seems to stop. The smartphone has become the essential worker that never gets a vacation. The problem that most hospitals face is that while in our personal life, we've adapted and adjusted every aspect of what we do to leverage that tiny computer in our pocket, we haven't made the transition fully in the hospital space. That is changing rapidly. While today less than 50% of hospitals have smartphones deployed, research tells us that within the next 2 years, that number will jump to 97%. The challenge? Most hospitals do not have a mobile strategy, and many don't even know where to start. We find hospitals pivoting their decisions on 3 or 4 areas. A device-focused strategy. Let me pick the device first, and then we'll figure out how to use it. Often this occurs in hospitals that have had a wireless phone prior, and that legacy hardware has become obsolete and no longer supported, which is necessitating a fast change. The EMR first strategy. Epic and Cerner both want to own mobility within your hospital. EMR has been your most important and largest investment. While identifying how it will be used in your overall mobile strategy is critical, Gartner highlights that the mega suite vendor's ability to be nimble and innovative is often challenging. EMR says it's good enough, and you have to determine, is it? Medical devices are also making their way into your mobile strategy. Your legacy hardware systems are pushing their agenda due to acquisition and desire to expand their footprint. They want to find a way to be more sticky. Determining their place in your strategy is an important decision, but I encourage you, get them to help you and not lead you. The final one is the collaborative vision based on the framework of the real-time health system. Gartner and other consulting agencies have built a framework that will enable you to make decisions based on your operational and strategic goals. We're going to explore that today and provide you with some feedback based on use cases and 2 key areas of the mobile strategy, communication and notification. But I'm getting a little ahead of myself. I want to introduce you to my friend. Will Lukens and I have known each other for 12 years, industry colleagues, and during his tenure at Centrac, occasionally even partners in crime. His knowledge of the industry and this topic specifically has been instrumental in developing this plan and vision that we are bringing you today. Will, would you mind sharing with us all some thoughts about the real-time health system and how we see that vision?
Not at all. Thank you, Kourtney. The real-time health system has rapidly become an essential cornerstone of healthcare mobility strategies. The real-time health system relies heavily on 4 tenets that you may want to translate into questions as you develop mobile strategy and evaluate processes and technologies to support it. The first tenet is aware. This is the box that many healthcare delivery organizations attempt to capture through command centers, the use of machine learning or AI. Aware covers enterprise-level situational awareness and visibility into critical patient events and clinical data. Aware is the most impactful and important tenet of the real-time health system, and for mobile strategy as well. It's how we drive operational intelligence beyond a static report into the hands of a caregiver. The second tenet is collaborative. The real-time health system not only allows for collaboration with key stakeholders around an individual's patient care within the 4 walls of the hospital, but also outside of the traditional acute care environment. Collaborative encompasses coordination, shared decisions, and even enabling patients and their families to be part of the care decision process. The third tenet is smart. Smart means that instead of relying on a human to make a decision, we empower the human with additional information that has been analyzed by a computer to speed it up or better the decision-making process. This allows the machine to consume information from multiple IoT devices, EMRs, RTLS, and more, and compile those pieces into a useful tool for a caregiver. The goal of this is that the machine becomes smart and learns from experiences, thus enhancing the care experience over time. The final tenet is real-time. The namesake of the entire concept refers not only to how information is delivered to the care team, but also how it is received and reviewed. It's what differentiates this concept from all others. It leverages all aspects of data aggregation and dissemination to allow technology to orchestrate workflow in a meaningful way. Before we go further, let's take a step back and ask a question. What is the goal of mobility? At Critical Alert, we look to answer that question in a non-traditional fashion. The ecosystem of the patient is made up of anything that rings, dings, and buzzes and indicates the patient's condition or need. These alerts can be physically, physiologically, or behaviorally generated or driven by documentation requests within the EMR or other tools. Thus, the goal of mobility is to ensure those data are delivered to the caregiver in a meaningful way, whether that's on a smart device, a computer, or other means of providing them with situational awareness about the patient and allowing them to make a well-informed decision to engage, escalate, or collaborate with other team members. Those actions and reactions are compiled into tools or mobility applications. Gartner's done a good job of organizing mobility applications into categories. At Critical Alert, we have coined those categories dimensions of mobility. The mobile tool can be used in a number of capacities through those apps that we show that fall into these categories. What we have found is the number of applications that have been developed to accommodate the ecosystem, for example, applications like clinical communication and collaboration applications, can be overwhelming. The question becomes, what app do I use, and whether or not the app will overlap with another system or technology that I've already purchased. Kourtney, can you help us with this challenge?
Sure. One of my first presentations with Critical Alert in 2018, before I became part of the family, was to speak about the dimensions of mobility. This was and still is an easy way for hospitals to create 4 buckets and fill those buckets with tools. It's become a great way to engage with our care leadership clients because we can develop a strategy based on function and not form. We can eliminate the vendor influence, except for documentation, of course, and focus on what matters to them in each quadrant. In developing this presentation, one of the things that Will and I discussed was that education and information is really something that's being absorbed into other areas. You see things like meds identification being absorbed by the EMR and education being consumed there as well. That being said, we replace that dimension with location. Location is and will continue to be a growth area for the dimensions of mobility. If I use my smartphone to find my way to work or locate my children when they're not home in time, or even my dog when she runs away, but I got a puppy during COVID, I'll be honest, and that was a mistake, and I may not want to locate the puppy, but I digress. We have an expectation around what the smartphone can do in the location dimension, and health IT companies need to accommodate that change. That's just a little sneak peek. Will and I will be presenting on location in the coming months, so stay tuned for that webinar. So next, I want you to take out a piece of paper. This is an interactive webinar. Take out a piece of paper and divide it into 4 quadrants. Right at the top of each quadrant, the dimension of healthcare. We'll use this as your notes sheet during the presentation and to help you start building out some framework for your own strategy. This is a simple process. I don't want you to be overwhelmed. Everybody can do it. Let's just take one quick example, and then we'll move into notification and communication. We're not going to spend much time on documentation because really this is a simple vendor decision. If you have Epic, you're getting Epic. If you have Cerner, you're getting Cerner, and so on. The real decisions start when you identify what and how will be moved from the computer to a smart device. So in the top corner, write the name of your EMR vendor under the header documentation. Then write out these questions. What pieces of my clinical documentation process are available on the smartphone? Will the clinical documentation process I want to track work on the mobile form factor? What needs to be done on the computer versus the phone? Does it reduce my use of a WOW or a COW or even those scanners that cost me so much money? Will I still need to use them consistently? What will change in my process for documentation if I add in a smartphone app, and is it going to work well for my hospital? And will I be able to do meds administration, and what are the limitations based on the device? There's a lot of hidden gems behind how the device can be used for scanning meds. See how easy this is? It takes that overwhelming notion that I have a mini computer in my pocket that I use for everything in my life, including ordering my coffee, as I did this morning, and make it into a managed decision. Now, Will's going to walk you through communication and notification dimensions. Then I'll be back to discuss analytics and workflow and how we will make some clinical transformation stick. Will, share with us a little about communication.
Thank you, Kourtney. The core functions of communication are voice and text. Communication is the cornerstone of smartphone usage. We use our personal phones mostly to connect with others. Greater than 50% of the time, that's a direct communication using an application for messaging or calling. The secondary usage is social media, identifying how we can incorporate both social aspects of messaging and social interaction as important. On your piece of paper, please take a moment to write voice and text and then write the words who to who. Every department that has a communication path and every care team member communicates with someone else to help make decisions about the patient's needs or to assist with patient care. While you're thinking through who talks to who and why, also note how is it currently done. Is this accomplished by department or service line? Then break it down by role, RN, PCT, pharmacist, doc, EDS, you get the picture. How do they communicate? Is it a phone call, an email? Do they use their personal phones to text?
Or a Post-it note. Whatever works sometimes will.
Sure, whatever means they're using to write it down so you can really see what your bottlenecks and gaps are. You need to cross-reference that with a when factor. One of the most challenging aspects of hospital communications is often with the doctors and surgeons. Who's on call? Who can answer questions? That brings me to one of the most overlooked areas of communication, the continuum of care. The hospital is no longer contained within four walls. In the past, when a patient was admitted, all the communication about that event was easily located within the hospital. Today, not only are there primary care physicians involved, but specialists and community roles like social workers or home health providers. This is no longer a conversation about what secure messaging platform will allow you to talk with the people associated to the care record in that moment. You need the ability to send a secure message to those who may not have the EMR application on their phone, or those who may not have an application at all on a personal phone, yet still need to be involved in the care of that patient. Creating an environment of care that enables and empowers the hospital care team to collaborate is essential to the success of your mobile strategy for communication. But there's another level that's fast becoming essential in the communication area, and that's video. Many of the clinical communication collaboration vendors are releasing video applications embedded into their platforms to enable face-to-face communication with patients and care teams. Video allows care providers to observe not only patient state, but also cognition and body language. It enables family members to be brought into the conversation, even if they are far away. Video allows for team care collaboration with multiple physicians and care team members to make the best decision for the patient. Video is not just a nice-to-have function, it's a must-have and should be considered during your evaluation of this dimension of communication. Some hospitals are already getting benefit from video today by using video communications with the patient to reduce the use of PPE. Using a tablet or even a television in the room with a camera, the care provider can dial into the room, have a conversation with the patient, and potentially reduce the need to enter. The next dimension we're going to discuss is notification. This is a core tenet of the real-time health system. While the other dimensions drive engagement or reaction from the assigned user of the smartphone, a notification, when delivered to the device in an effective way, drives situational awareness. Situational awareness occurs when a caregiver can tie information together to enable someone to make a faster decision. Traditionally, alarms and alerts were just a push and replication of what we originally had from the signaling technology and what it was spitting out. But we found that developing our own Common Path Connect application and working with a number of other vendors, that simply replicating the sound from the bedside to the person's hip can often be more harmful than helpful. The notification piece must be combined with multiple data points to be effective. An alert is not enough. An alarm is not enough. Providing context and the ability to add additional information into the mix is essential. Let's switch gears for a moment and discuss nurse call. One of the challenges we see today with traditional nurse call systems is their attempt to absorb functions of multiple software platforms. They've taken a hardware-based mentality and expanded it to other applications, trying to control the client with hardware and creating barriers for other functions. It is also known as the walled garden approach. In this graphic, you can see how traditional hardware-based nurse call is reaching into multiple solutions, including EMR to capture documentation, patient education, and even clinical communication and collaboration. We know that large players in the market are requiring the purchase of hardware to enable the functionality of mobile or software applications. It's just crazy. Why is a staff terminal needed to push documentation into your EMR? Gartner has been promoting the concept of the next generation of nurse call, which promotes the idea that you can gain more features and functions from a software-based platform than a hardware-driven platform. We at Critical Alert believe the convergence of alarms and notification, clinical communication and collaboration, interactive patient care platforms, and aspects of nurse call can only be achieved if you remove the barriers of hardware and enable the forward thinking of software. As you're evaluating the aspects of notification for your mobile strategy, ask yourself this question. To gain workflow automation, do I need a piece of hardware in the room, or can that be accomplished with the hardware currently in place? Kourtney, what do you think? How would you answer that question?
Well, I'd say absolutely not. We shouldn't want hardware to dictate a workflow or even data. And data is really where we're going next. In nursing, there's this ability to synthesize information, leveraging touch and sight and sound, in addition to all the other compiled pieces of information from the medical record. But it's more than that. It's adding bits and pieces from conversations with other care team members, family members, and even the patients themselves. We know that one of the most challenging groupings of information is actually that of alarm management. The patient call light is triaged by sometimes multiple people. The alarms from telemetry or vitals blend together in the mind of the nurse, making that compiled understanding of the patient need difficult for the care team members to synthesize into what we call knowing. We know that being able to pull data from multiple locations, combine it into algorithms and visualizations is only the beginning, but even that can be overwhelming. We're going to attempt to answer some of these questions in the next few slides using some use cases and examples, and we'll walk through how the data can tell a story that can empower care leadership to make meaningful change. We're going to start with strategic objectives and align those with initiatives, then tie those to dimensions of your mobile strategy. I know that sounds a little complex, but really it's quite simple, and I know you can do it, and we're glad to help you with it. Step one, when we work with a hospital, we start with strategic focus, the real why of the project, and not the what or the how or even the who. Why are we investing this money? Why are we changing our technology? Why does it matter to patients, caregivers, and the hospital? Primarily, we end up with 3 or 4 categories. I call them big rocks. They are the high-level strategic objectives that encompass multiple measurable programs or initiatives. In this slide, you're just going to see 3 of them: patient satisfaction, patient safety, and caregiver burnout. Once you have identified your strategic objectives, determine some key initiatives that will help you move the needle. For example, under patient satisfaction, we would note HCAHPS 4, improve response to call light score in post-discharge survey by 10% in 60 days. While it's important to put an actual quantifiable number and a timeline to that initiative, remember, these initiatives don't really have an end, because even when you achieve the goal, you still need to monitor and manage it, or you will slip into old behaviors. Once you've done that, tie it back into the dimension. This will help you figure out where you're going to find the data elements to manage. As you can see on the screen, I circled the initiatives and drew a line back to the dimension of either notification or communication. Next, you identify what you need to measure. If I want to improve patient satisfaction survey responses for HCAHPS 4 by 10% over 60 days, then I need to identify what to measure from the process and to help manage that change. Remember, we leverage technology to enable process change. However, to adopt that new process, we have to shift old habits into new habits, which is a behavioral change. To manage a behavioral change, we have to find a way to hardwire it into our daily lives and leverage technology to drive situational awareness. Let's think about something super practical that I hope everybody can kind of understand and maybe think about. The Weight Watchers app works because it constantly tracks progress through the week. The scoring system they use encourages you to eat healthy food with no points. For example, I can have all the apples I want until I hate apples. But that piece of chocolate pie that I had for my husband's birthday, let's just say mistakes were made and I used all my points for 2 days. It was a points buster. The app drives situational awareness, which allows us to adhere to a behavioral change and changes the patterns that we have adopted and ultimately reach your goal. You can't make a major life change by focusing on the end result. You make a change by dissecting the process and identifying segments worth measuring. As you can see, you can really start to align your strategic objectives back into specific initiatives, and then you can identify items to measure to move the needle. This is an example of how your communication dimension could be broken down by strategic objectives of safety, satisfaction, and caregiver burnout. Take a look at caregiver burnout section. This is one of the core areas we see easy measurement on the communication dimension. I encourage you to look at messaging in a new way. Think of it as workload. Sending, receiving, answering, and interacting with a text is a task, and it should be considered in the daily workload understanding of the clinician. We do that a lot with alarm management. In there, I call it variable acuity modeling of patients because it varies based on their activity level. In communication, the secure message is just like a text on your phone. And if you're busy in the day and your workload is high, you may not be able to answer it, review it, or act on it. So we need to look at messaging as workload. And this means taking a global look at one-to-one texting, team texting, and global and group texting. All of those equate to workload and can cause burnout if they're not managed effectively. One of the challenges I see in the market today with the CC&C vendors' data analytics are they're primarily focused on adoption. How many users are on the system, sending messages, messaging quantities. Some vendors on the market can't even extract their own data to expose elements that will help you build a strong data strategy. This is a critical question you should be asking during your evaluation process. And let me just share, if you are in the evaluation process of CC&C vendors and want more questions to ask them, please reach out to me. I'm glad to share more information. The industry's current state will only help you initially. You need to drive those vendors to produce analytics that capture process change and provide it back to you in real time so that you can make meaningful adjustments to your staffing, workload, and interactions. Another tip, when you're looking at measurements of portions of a process, you'll be able to identify patterns. My mom has been teaching me to quilt. One of the basic quilting blocks is called a half square triangle. The half square triangle, when turned in different ways, creates different patterns. It's the exact same technique and the exact same seam allowance, but flipping it and combining with different solid blocks can produce a really new result that's quite impressive. The same will be true of your process. Let's look at this data example. Many hospitals have a policy that you should not leave a patient in the bathroom unattended, especially not one that's a fall risk or needs assistance to get in and out of bed to go to the bathroom. The data captured and visualized shows that the patient has used their pillow speaker call button. That's the orange dot. And we can infer it's for assistance to the bathroom since the next icon is the green triangle, which is the pull cord in the bathroom. This pattern identifies that the patient was most likely left in the bathroom unattended and told to pull the pull cord when they're done. Why do I infer that? Because you can see a number of similar patterns. If there was only one or two, maybe the nurse was in the bathroom with the patient and pulled the cord to get help for both of them, but there are multiple. And that call alarm hit every nurse on the unit, and it was an emergency, so they all had to run to the room. Plus, the hospital's policy was not to leave the patient in the bathroom unattended. Patterns tell you so much. That pattern we just looked at was actually from a call light system, which is from the notification dimension. The data from the nurse call and other alarm and alert technologies is so rich, but people often overlook it. It's used when there is an incident, such as a fall or a patient complaint, or if the system isn't functioning correctly. But they overlook the fact that it reveals behaviors of the patients and behaviors of the reactions and interactions of the care team. One of the areas we most often focus on with a hospital in the notification dimension is safety. The way alerts and notifications are set up, the way caregivers receive and interact with those alerts, the way they have access to data for understanding are hugely impactful to being able to move the needle on patient falls. Every single account I work with, we talk about patient falls and how technology can help support their effort to reduce them. Let's think that through and talk through adding some new technology to really change and move the needle. I want to introduce you to Mrs. Jones. She's a 75-year-old woman with C. diff and low blood pressure. We also know her well because she's a frequent flyer. We can use the data and analytics tool to individually identify if a patient is exhibiting risky behaviors. Mrs. Jones has been admitted to the hospital for the last 48 hours. This is a longitudinal data example that shows her patterns of behavior on two different units. You see how they're the same? Let's first notice some attributes of the pattern. First, there's a high quantity in close sequence of bed exit alarms. That's the blue star. Second, there is no patient use of the pillow speaker on a consistent basis before exiting. That's the orange dot. That alone is concerning, but if we look further at the data and we use the rate at which it's occurring at 1.88 per hour, meaning almost twice per hour, the patient is creating an alarm that makes you run to the patient room. That information level sets our understanding about this patient. So what if Mrs. Jones called in? Let's look at if we had some different technology to enable knowledge and knowing about this patient. Think about how currently you triage a call from patients like Mrs. Jones. Now let's talk about it in this new way. With new technology, if the patient uses the call light, then the command center can identify that the bed is set up with the fall compliance. Simply by clicking that button and expanding the screen, they can see every aspect of the bed. The person in the command center can immediately inform the nurse, or the nurse has the ability to see the bed status on their smartphone. Isn't that amazing? Whether he or she has received a call or not, the care team member has access to bed position, status, like breaks, rails, position, height, etc., in a very nice visual form. Based on the behavioral patterns of Mrs. Jones, the care team may decide to adjust the rounding process, which can also be activated directly from their smartphone. You don't have to enter the patient room, suit up in PPE to push a button on the wall or a staff terminal or other tools. Just use your smartphone and touch that button to set a reminder about rounding. And then you can actually perform the round from your smartphone as well. Isn't that amazing? Further, we can review the data in real time on the smartphone or tablet. One of the ways you can use data in real time is to look at trends and data points. Trends matter when balanced with details. A trend tells you when things are occurring in aggregate. Aligned with details, you can view and see where pockets of risk are indicated. Remember what I said about half square triangles? The way the pattern occurs tells you everything. If you shift to this view by caregiver or care team, you'll be able to see workload variations and even care team interaction variations that will help you identify if staffing needs to be adjusted in this process. So how does care leadership support their staff in this new data-enabled scenario? One example is our leadership rounding platform has a patented algorithm which automatically, is like I say it, which automatically captures the patterns of behaviors like Mrs. Jones is exhibiting. Without looking at any scatter graphs at all, you can identify which patients are exhibiting risky behaviors, making you run to the patient room. The automation of the pattern into an algorithm allows you to be laser focused on which patterns you need to do a quality or patients you need to do a quality or safety round on. And by compiling both qualitative and quantitative behavioral information of both the patient activities, the caregiver's reactions, and their feedbacks, you can do a crazy informed round. By taking a multifaceted approach to your data, you will be able to make meaningful change. You will have to take it beyond a report in the dashboard. If a dashboard is 2 hours old data, is it really a dashboard? Is it really worth looking at? Your signaling hardware should not dictate how you experience the data, whether it's Rollin, Hill-Rom, ASCOM, or even Critical Alert. Data is generated by all of them, and you should be able to leverage that data in real time in reports and tools. I've worked in the vendor community for nearly 20-something years, and as a consultant, or as I say, a client advocate, it's surprising to me the lack of understanding of data by our vendor community and the onerous nature of the conversation about data. It's not theirs, it's yours, and you should be able to choose how you use and consume it. Because the only way you're going to take it to the next level is starting to combine multiple data points into new and informative algorithms. If you can get a hold of your data, then you can take it to the next level. Once you are employing both a secure messaging platform and sending alarms and notifications to the device, then you can start to evaluate multifaceted metrics. If you take a look at this diagram, part of the data is captured in the alarms and notification platform. Part of the data is captured in the secure messaging platform. Neither would give you a full picture. However, if we combine those two sets of data, if we stitch them together, as my VP of R&D, April, likes to say, then we get a holistic understanding of the life of that request. To quote Emerald Gassi, if you want to take it up a notch, add in location. It's one of the most data-rich elements we can add in. Aligning location with behaviors and interactions is really critical to creating a solid improvement plan. But Will's going to share just a little bit more about that. Will?
Thanks, Kourtney. Adoption of RTLS in healthcare has taken off over the past 5 to 10 years. While most healthcare delivery organizations have at least experimented with one RTLS application, typically a point solution or departmental application that might solve one or two problems, very few have reached the potential that an enterprise RTLS offers. In fact, it's Critical Alert's belief that the deployment of an enterprise RTLS, which locates assets, patients, caregivers, and visitors, yes, visitors, within the real-time health system offers significant return on investment in the range of $12,000 to $15,000 per bed. And it's not just about tags anymore. Enterprise RTLS integrates the location of mobile devices in the clinical workflow. If you'd like to learn more about the value RTLS can offer your organization, please tune in for Critical Alert's next webinar, The Benefits of Enterprise RTLS.
And that's all we have. Betsy, did we get some questions?
We did. The first one is, who do you suggest should be involved in the development of a mobile strategy if we don't currently have one?
My initial recommendation is if you have a chief nursing informatics officer, that individual should be the lead, because that individual has had the background of doing a clinical transformation project that's massive. And moving to a mobile strategy is a massive project, and it touches a lot of different aspects. But that individual has been able to transform the way you do documentation from a manual process into a digital process. So they have experience there. So that's one of my main recommendations. And while I recognize there has to be a cross-functional team, I feel like the CNIO is really a key person within that. Will, did you have anything to add?
Sure. I also want to say the IT team will need to be shepherds of the process for devices and integrations, for alarms and notifications. Their subject matter expertise is going to be vital to the project's success. The telecom, clinical engineering, networking, more or less a cross-functional team is the right way to go to make a project like this successful. And some hospitals don't necessarily have all these roles, but if you have questions about who you might want to involve, please reach out to us and we can help.
Thank you. Second question we got was, old habits die hard. How do we change staff's mindset about going mobile when they've been using Post-it notes to communicate as long as they can remember?
You know, one of my first hospital experiences, I was thinking about this last week when I was talking to Crystal, who I've worked with for almost 15 years. We were at a hospital and we watched someone write information on Post-it notes. So they'd receive a call in the call-out system, they'd write it on a Post-it, and then when the nurse would walk by, they'd hand them the Post-it, and they'd kind of go on from there. And so everything was always lost in the shuffle. I would say one of the biggest things you can do to shepherd this process, I love that phrase, Will, to shepherd this process through, is to enable situational awareness. If you're just sending an alarm and alert to a CC&C platform, you will have some trouble with adoption. The clinical team will like the abilities to send text messages, to interact, to receive information. But if you're not giving them some of those situational awareness items like data and giving care leadership real visual data and understanding, then you won't get a good adoption. Let me give you another example. We were working with a hospital one time, and the way that their bed exit alarms worked was everybody on the whole unit got it every single time to their smart device, and then it replicated itself really rapidly. We know that's not a great process. That can cause some crazy alarm fatigue. So we were able to give them a visual understanding of what was occurring and show them that critical request rate, and then show them how we can make a change to the process. So don't put something in the pocket of the nurse, and you're not going to reduce workload or noise or anything like that by doing that. Don't do that until you have the tools to actually measure visually in real time, not with a delay. Be very careful when you're evaluating these products. A lot of them are cloud-based, and the analytics then have a 2-hour lag time because of the way they batch the data into the cloud. Thanks, Betsy.
Thanks, Kourtney. We have one more question that came in. It is, do we have to get the EMR vendor or other vendors involved when deciding what smartphones we're going to purchase?
Well, you would have to get the EMR vendor involved a little bit. So EMRs can function they generally have the ability to function in both iOS and Android, but sometimes there's gaps in what they can and can't do. So you would need to talk with them a little bit and say, what gaps am I going to have if I go with an Android or if I go with an Apple product? And then you just need to evaluate those gaps. So if all of the programs or all of the modules from the EMR don't work on one of the other applications, you can just say, am I actually going to use that module? Don't let that be the deciding factor for picking a smartphone. You need to say, am I actually going to use that module? Is that important to me? Will, did you have anything else to add on that one?
I would just add that in terms of other vendors, we see a lot of companies are trying to make their way to own the smartphone, sort of a pivot to the walled garden model. So just be aware of that as you work with various vendors.
Any other questions, Betsy?
No, that's it. Thank you
Great.
so much.
Thank you all for attending. Please reach out if you have additional questions. We're glad to answer them.